morning, everybody. Welcome to HIV Grand Rounds and our third and final CROI 2025 report back. We have or are finishing our series with really a star-studded group. And I'll say that we have a special presentation in the last 10 minutes of our HIV Grand Rounds. So I'm going to quickly introduce our two speakers, Dr. Susan Buchbinder and Dr. Hyman Scott, and then we'll get right to it with questions at the end of both of their talks. So first off, we'll have Dr. Susan Buchbinder speak, who is the Director of HIV Prevention Research at the San Francisco Department of Public Health, as well as a professor of medicine and public health in epibiostats at our University of California, San Francisco. She is an international leader in HIV prevention and leader in trials from vaccines through implementation efforts. Dr. Buchbinder, in addition to having her own Wikipedia page, which I learned this morning, is also co-director of the Getting to Zero Consortium here in San Francisco. She will speak on HIV prevention primarily, and Dr. Hyman Scott, who is the clinical research medical director at Bridge HIV and an assistant clinical professor of medicine at UCSF, will speak second, primarily focusing on DuxCPEP as well as other STI prevention science. So let's give them a warm welcome, and thank you so much for being here.
Thank you so much. Welcome, everyone. This is what I'm going to cover. I'm going to start off with a little bit about HIV epidemiology and the current landscape, and then we'll talk about PrEP rollout, breakthrough infections on CAB-LA, and new PrEP regimens. So if you didn't see it, I really recommend that you see Chris Byers' plenary talk. He gave a phenomenal plenary in which he talked about the state of the current epidemic. And what you can see here is that we're off target to meet our 2025 targets. In 2023, there were 1.3 million new infections, and our 2025 target is less than 370,000. So we're well off target to reach those goals. There's been progress in some parts of the world. So on the right-hand side, you can see the change in new infections between 2010 and 2023. And on the left-hand side is the distribution of new infections by region. And now more than half of the new infections are outside of sub-Saharan Africa because we've had such dramatic declines in new infections over that period of time in that region of the world. But you can see that in Latin America, Eastern Europe, and Central Asia, and the Middle East and North Africa, we've actually had increases in new diagnoses over that time period. So let's start with our first audience response question. What proportion of PrEP is administered worldwide comes from PEPFAR? Oh, I've got to go to the next slide. Okay, sorry about that. So we've got half say 50% and half say 91%. It's actually 91%, which is just remarkable. So with this freeze in PEPFAR, and particularly a freeze in all PrEP except for pregnant and breastfeeding women, you can see that we're really taking a huge hit in terms of our PrEP distribution worldwide. And this is just a brief overview of the impact of the PEPFAR freeze. You can see on the left-hand side that in respondents from 27 countries, there was massive either reduction in activity or cancellation of all activity. It was estimated that there'd be 220,000 people per day, including over 7,000 children unable to access needed treatment in the first month after the freeze. 3,600 new adult infections, and just in the next 4 years, 8.7 million new infections, 6.3 million AIDS deaths, and 3.4 million AIDS orphans. So really dramatic impact of this freeze. The other thing we have to remember locally here at home is that we do have these tremendous disparities. So these are the number, this is the HIV incidence in men who have sex with men. And you can see while we've made progress in white men who have sex with men in the yellow line and the purple line, Black African Americans have stayed pretty stable since 2010. So we really have a lot of work ahead of us. So let's talk about what we can do about prevention, and we'll talk a little bit about PrEP rollout. This was a poster presentation on the laboratory testing and whether or not we're actually adhering to CDC guidelines. And so this is national data from Market Scan database from 2022 to 2023. And what the CDC recommends is that HIV laboratory-based testing be done at initiation and follow-up visits. So not just a rapid test, but a laboratory-based HIV test. STI testing at initiation and follow-up visits, Hep B testing at initiation, and creatinine testing for oral PrEP users. And what you can see on the top is the oral PrEP users, and over 35,000 oral PrEP users with over 12,000 who had follow-up prescriptions. Only 38% had lab-based HIV testing at initiation, and only 56% at follow-up. And then in terms of CAB-LA, only 55% had lab-based testing at initiation and 82% at follow-up. And then if you look at STIs, they were substantially under-tested, particularly at initiation, but also potentially at follow-up. So my next audience response question, according to data from IQVIA commercial prescription database, approximately what proportion of PrEP users in the US in 2021 and 2022 persisted on daily PrEP use for at least 6 months? So how are we doing in terms of persistence? Okay. Well, half of you got this right. It's 40%. Some of you are more optimistic, and we hope that we can get there. But again, these investigators used the IQVIA commercial prescription database, and they counted persistence as just having continuous PrEP for at least 30 days. The non-persistence was more common in women, in people who were younger, and that's compared to 55 to 64-year-olds. So really a broad swath of individuals. Black, Hispanic, and other races and ethnicity, public or cash payment. Every region outside of the Midwest was worse than the Midwest, and 2021 to 2022 was actually worse than it was in 2017 to 2019. So only 40% of new oral PrEP users continued PrEP until 6 months. The median time on PrEP was only 3 months. So people are getting PrEP prescriptions and they're not staying on it. And we need to do more in order to support people. It doesn't take into account people who might have switched to 211 or who might switch to CAB-LA, but we think that's probably a minor proportion of individuals. So this was a fabulous presentation by Matt Spinelli, in which he pointed out that young men who have sex with men have high HIV incidence, and challenges with PrEP adherence are common, and that there was a prior study in Kenya in women using a point-of-care urine test for tenofovir that demonstrated improved long-term PrEP adherence when you gave women those results back at the time of testing. So he did a study in 49 US men who have sex with men who were under the age of 30, randomized 2-to-1 to point-of-care tenofovir tests using 2 30-minute counseling sessions that incorporated information about the urine test versus standard of care, and all of that was done virtually. And of the 31 participants in the intervention arm in this pilot study, all of them successfully self-administered the urine tests, and all reported the intervention was somewhat or very acceptable. So really a great result. And then if you actually look at impact over a 3-month follow-up, increase in hair levels of tenofovir were consistent with 1 to 2 pill increase per week. So a really substantial difference. And in fact, if you take 8 of the intervention participants who didn't have at least 4 doses a week, 6 of them then had more than 4 doses a week, compared to 0 of 4 control participants. We got some data from Kaiser as well. We're going to talk next about CAB-LA rollout. And in Northern California and the Mid-Atlantic states, DC and Maryland and Virginia, those 2 Kaiser Permanentes account for over 5.4 million users. CAB-LA was implemented in May of 2022 in Northern California, and in March of 2023 in the Mid-Atlantic region. And what you can see on the left is, in the green is the Northern California, and then this is the Mid-Atlantic states. So it looks like the numbers are rising, but still, of 23,000 PrEP users during the study period, less than 1% had started on CAB-LA. So we're not doing well at all in terms of rollout. there. But the good news was that compared with oral PrEP users, CAB-LA users were less likely to have commercial insurance, and they were more likely to be Black, Latino, have a prior bacterial STI, or have hypertension. So some of the people who were having a difficult time reaching with oral PrEP were getting CAB-LA. So that's good news. And on the left-hand side, you can see also this is persistence on CAB-LA. And again, good news compared to the 40% persistence, this at 6 months was 88% and at 12 months was 75%. And then of the 35 individuals who discontinued CAB-LA, 34% had oral PrEP prescribed after stopping CAB-LA. So it wasn't a complete discontinuation. So CAB-LA uptake was low, but the persistence was high, with over 90% on-time injections or early injections. There were no incident HIV infections in people who were getting CAB-LA. And CAB-LA was reaching populations that were underserved by oral PrEP, including 24% of the CAB-LA users had no history of taking oral PrEP. So we were expanding the pool of people on PrEP. So that was a good thing. And then real world data did guide implementation there. So they found that the loading dose of was more likely to have a late injection. And so it required more close follow-up at the beginning when you're starting somebody on CAB-LA. And that we also need to counsel people on bridging as well as switching from CAB-LA to oral PrEP. Then there was an interesting CAB-LA study out of Brazil in which they had 6 PrEP clinics in six Brazilian cities. And they enrolled men who have sex with men, transgender and non-binary individuals who were HIV negative, 18 to 30 years of age, PrEP naive, and seeking PrEP or getting HIV testing. And they had all had an option to get either CAB-LA or oral PrEP. 83% chose CAB-LA. So it shows again the importance of choice. And they compared the PrEP coverage with 14 other Brazilian PrEP clinics where only oral PrEP was available. And they defined adherence as having no more than a 2-week, an injection 2 weeks late for initial or subsequent injections for CAB-LA, and enough pills for at least 4 doses per week. And what you can see on the left-hand side is that 94% of individuals were on time, and it only dropped as low as 92%. And then on the right-hand side, each of these horizontal lines, which you can't really see as an individual person, but in blue are the covered days with PrEP. And the orange lines are uncovered days. And you can see that there was 95% coverage of time on CAB-LA compared to only 58% for the oral PrEP choice cohort. And then compared to those 14 clinics where people didn't have choice, only 48% of the days were covered. So we got better coverage with CAB-LA as well as having better outcomes. So there were no seroconversions in the CAB-LA choice cohort. And remember, that was the largest cohort. The oral PrEP choice cohort had 1 seroconversion, which was a 1 per 100 person year incidence rate, and 9 seroconversions in the oral PrEP comparison cohort, which was a 1.5% per year infection rate. Only 6% were lost to follow-up. Only 3% required CAB-LA reloads. And there was some switching that happened. So there were 9% of people who went from oral PrEP to CAB-LA. And the main reason was that they didn't want to take a daily pill. And 4% switched from CAB-LA to oral PrEP. And the main reason there were side effects, and it was mostly injection site pain. So again, choice is so important. And we've seen that with the SEARCH study, and now we see it here as well. One of the big questions is, what do you do in terms of monitoring people who are on CAB-LA? Because some people have delayed seroconversion. So the question is, do you do RNA screening at each of their injection visits? So these data came from HPTN 084, which was the women's CAB-LA versus TDF-FTC study. In the blinded study, everybody got either an actual injection of CAB-LA and a placebo TDF-FTC, or a placebo CAB-LA and an active TDF-FTC in the blinded phase. And then in November 2020, the DSMB recommended unblinding because CAB-LA was superior to TDF-FTC. At that point, everybody got to choose what they wanted to take. So they'd all been getting injections and taking pills, and 78% chose CAB-LA. So again, importance of choice and importance of making CAB-LA available. In the randomized control trial, the only RNA testing was done at the screening visit. Otherwise, they had rapid tests and or antigen antibody tests at each visit. So in this open label extension, they moved to doing HIV RNA testing at each visit to see how well it captured people. So there were almost 2,500 people included, including over 24,000 RNA tests. Over 20,000 of those were on CAB-LA. And of those, 87 had at least one reactive HIV test. Only 8 or 9% had HIV confirmed, and only 4 of those had an isolated RNA. So they only picked up 4 additional infections in the entire cohort, 3 of them on CAB-LA, 1 on TDF-FTC, and there was no INSTI resistance. 77 of them were found to be HIV negative. 12 of those had an isolated RNA, 5 of whom actually had a CAB delay of over 10 weeks while they were trying to sort out whether or not people were truly infected. So there's a cost to doing this RNA testing, in that there was a 3-to-1 ratio of false positives to true positives, and those false positives were not getting PrEP during that period of time, so they were vulnerable. They were also unable to differentiate true positives from false positives based on quantification of RNA. So the authors concluded that we should consider costs and risks in developing testing algorithms. And last year, Rafi Landovitz presented data from HPTN-083 that showed that the positive predictive value of a single isolated RNA test was only 9% in people who are actively getting CAB-LA. So you do a lot of chasing after false positives. So let's talk then about breakthrough infections on CAB-LA. Of the 47 participants in HPTN-083 who were exposed to CAB-LA who became infected with HIV, what proportion achieved viral suppression on their first antiretroviral regimen? Everybody said 93%. It was actually 77%, and I'll show you the data, but it may be a little bit better than that if you're not quite as strict with your requirements. But first, let's talk about Kate Koss's really nice presentation on 7 people diagnosed in clinical care on CAB-LA with breakthrough infections, and this was national data for people who were referred to this study. 6 had on-time injections, and 5 of them had protective levels of CAB. So we know that CAB is not 100% protective. It's quite protective. So this is still a fairly small number, but there were 5 who had protective levels of CAB. 4 of them had non-reactive HIV antigen antibody tests at their first detected positive results. So again, you are going to miss people when you only do screening with antigen antibody testing. 5 of them had INSTI resistance mutations. 1 had high frequency resistance mutations on population-based sequencing, and 4 had additional low frequency resistance mutations on a sensitive research assay. All 7 of them were started on darunavir-based ART and achieved viral suppression to less than 20 copies per mil. And then 3 of them with the low frequency resistance mutations were switched to a provider-selected INSTI-based ART and maintained viral suppression over 13 to 31 weeks. So the authors here concluded that long-term follow-up is needed to determine the clinical significance of low frequency INSTI resistance mutations and the durability of suppression on INSTI-based ART. So let's turn next to doing what Rafi presented were the 47 breakthrough infections on HPTN-083. He had a beautiful presentation with lots of animation, but it went by very quickly. So I'm just summarizing it here. Resistance testing and viral load were done centrally and not available to the site. So the sites had to do their own resistance testing and track viral suppression. 71% suppressed on an INSTI and 81% on a non-INSTI regimen. So that's where we get to the 77% overall achieved viral suppression. But an additional 3 on the INSTI and 1 on the non-INSTI had viral loads of just 50 to 78, so very low level viremia. 5 of the non-INSTI regimens switched to an INSTI. And 4 of those suppressed and 1, they don't know what happened. So it looked like the switching worked well in this study as well. 41 participants had resistance testing available. 9 of them, or 22%, had INSTI resistance prior to treatment, and all of the people suppressed, including the one who was treated with an INSTI who had an R263K mutation. 2 of 3 without genotype testing failed to suppress, 1 each on an INSTI and a non-INSTI. And the conclusions that he reached were that similar results were seen for INSTI and non-INSTI regimens, but we need longer-term follow-up. So let's talk about new PrEP regimens, because there's a lot that was exciting that was presented at the meeting. I'm not going to go over the lenacapavir once yearly results because that was presented last week by Annie. But if you look at the Purpose 1 study, it answered a very important question about, does TAF FTC work in cisgender women? Because currently it's not approved for receptive vaginal sex. And it hadn't been tested in women previously in a randomized controlled trial. So in this study, they compared lenacapavir and they compared FTAF to background HIV infection rate based on women who came in who were HIV positive at enrollment. And then a secondary analysis was looking at it compared to FTDF. And on the left-hand side here, you can see the incidence in the FTAF arm was 2, a little over 2 per 100 person years, which was not significantly different from background rates, which was disappointing. But it also wasn't significantly different from FTDF. And we know that FTDF works for cisgender women. So we know that when it doesn't work, it's because of adherence. So was adherence the reason here? The green bars on the right-hand side are showing high levels of adherence. That's 4 or more doses a week. The yellow bars are medium adherence, 2 to 3 doses a week. And the red bars are low levels of adherence, less than 2 pills a week. And you can see that high and medium adherence declined over time through 52 weeks of follow-up. So there was really an adherence issue. And if you look here at longitudinal adherence patterns, each of these rows now is an individual seroconverter. The dots at the end show the times when HIV was detected. And the light green shows low levels of less than 2 pills a week. The medium green shows 2 to 3 pills a week. And the dark green shows 4 or more pills a week. And you can see that from almost all of the infections, there was low levels of TDF-FTC present at the time that HIV was diagnosed. And so they compared then on the left-hand side, the people who became infected who were on FTAF, sorry, I meant FTAF. And on the right-hand side, the people who didn't become infected who were on FTAF. So while adherence wasn't great in the entire cohort, it was really bad in the people who became infected. And that was very similar to what was seen, the comparison of FTAF in the Men Who Have Sex with Men and Transgender Women study, Discover. So they concluded that HIV acquisition risk was 89% lower in women who took at least just 2 pills a week. So that was pretty, I think, encouraging that we could use FTAF for cisgender women. And hopefully the FDA will take that under advisement when they're looking at the Purpose 1 results. Another question is, can women use on-demand PrEP? So we have 2-on-1 PrEP for cisgender men and transgender women, but what about cisgender women? And what we know is that tenofovir levels, both tenofovir and tenofovir diphosphate, the active metabolite, are much lower in the female genital tract than they are in the rectal tissue. And this is a log scale, so it's really, it is a substantial reduction. The only thing that's higher in female genital tract is the active metabolite of FTC triphosphate, but that declines very rapidly after administration. So there are data from HPTN 083 and 084 that do show that with low levels of adherence, 2 to 3 pills a week in transgender women and gay and bisexual men who have sex with men, you can get over 99% protection. Whereas for women, it's lower, it's only 88%. This is for cisgender women. But cisgender women who take 4 to 6 pills a week still have about 90% protection. And so Mackenzie Cottrell did this PK/PD analysis in which she looked at, you lose drug in the female genital tract more quickly than in the PBMCs and in the rectum. And based on her model, she predicted that 211 would provide 85% protection for 5 days after sex. And that if you increased by just 1 day, if you did 2111, that it would increase the protection by 8 to 15% more. So she was really calling for this to be explored in clinical trials. So it may very well be that women can use an on-demand regimen. And then finally, I'm going to close with some in situ forming implants that were presented both by itself as cabotegravir in a non-human primate model, as well as a multi-purpose technology tool, using it combined with an oral hormonal contraceptive in mice. So these are injectable biodegradable copolymers that can be removed, and that leaves you with a very short PK tail. So one of the concerns we have with, for instance, with Cab-LA is if somebody goes off of it, there's a very, very long tail where people might have too low a level to provide protection, but high enough to select for resistance. So if you've got a removable implant, then you can actually just get rid of the drug entirely. And what they did was they looked at this with CAB in situ forming implant, and in a rectal challenge study, it provided 100% protection with sustained delivery of cabotegravir for about 6 months, and it was safe and well tolerated for more than a year, even when it wasn't removed. They also then tested in mice combined CAB and hormonal contraceptive with medroxyprogesterone acetate, which is what's used in Depo-Provera. And they had high and sustained concentrations for over 180 days, and it was safe and well tolerated in mice. And I'm going to show you some of those data now. The exciting thing is they took 6 mice. 3 of them, they removed the in situ forming implant at 3 months, and the other 3, they kept it in. And what you can see is that they suppressed ovulation for 6 months when they left it in, but as soon as they took it out, the mice started ovulating again within 2 to 3 weeks. So it would be a reversible contraceptive. And similarly, the Cab-LA stayed at high levels if they left it in, but as soon as they took it out, it dropped to below the level of quantitation. So again, really great reversibility of this multi-purpose technology. The in situ forming implants were well tolerated. These are the 3 animals that went for 6 months that had no local skin reactions, mild skin reactions in 2 of the 3. And then 1 of the 3 had moderate to severe reactions, but they resolved within a week after using non-steroidals and antibiotics. And then they did X-ray studies that demonstrated complete removal at 3 months when they took it out, as well as no migration through 6 months when they left it in. So the authors stated that warrants CAB and MPA in situ forming implants to be tested in women. So again, really exciting if we could move forward with multi-purpose technologies. So these are my clinical take-home messages. Get lab-based HIV antigen antibody testing when starting PrEP, particularly for Cab-LA, and remember to do STI testing. Don't do RNA testing for routine surveillance testing in patients on Cab-LA, because you'll end up chasing a lot of false positives. In some settings, adherence to Cab-LA is quite high, as is coverage of sex. So choice is very important, and we should be offering Cab-LA where we can. Although breakthrough infections with on-time Cab-LA are rare, they do happen, and additional data are needed on long-term outcomes with different treatment regimens. And then there are exciting new possibilities for HIV prevention. For PrEP, once yearly IM lenacapavir, and the possibility of both TAF-FTC and 211 or 2111 for vaginal exposures, and then these multi-purpose technologies with in situ forming implants. So I raced through that so I could leave Hyman some time to talk about STIs, which he'll talk about next.
Thank you, Susan. So I'm going to talk a little bit about STI prevention, which is exciting data presented at CROI this year. So there's some studies that came out of the San Francisco AIDS Foundation. Mike Berry provided an analysis looking at the DoxyPEP continuum, which was conceptualized as being a way to evaluate, in the similar way we have the PrEP continuum and the HIV cascade, what is happening for DoxyPEP in one of our large STI clinics. So these were the steps into the continuum that we identified, which was an indication for DoxyPEP, receipt of a prescription, and then initiation of DoxyPEP use, which you can see here, were based on guidelines, and then some of the EMR data that we're able to collect from the patient records. And we also wanted to take a look at what the social determinants of health, how they impacted each step of the continuum, and sort of build this out so we can track how we're doing in terms of equity. So this is what the continuum looked like. So of those who had an indication for DoxyPEP, only about 59% received a prescription. And as we know with PrEP, and as Susan mentioned, not everyone who receives a prescription actually starts. So 61 of those individuals who were received a prescription reported taking at least one dose. And then 61% of those reported high adherence. So really we had this drop from down to 22% of those who were indicated for DoxyPEP actually adhered to it. What we saw when we looked at the social determinants of health, that among youth, it was lower. It was lower among Black African American clients in the system and those who were unhoused or unstably housed. And also, we saw a lower use among individuals who were living with HIV in the sexual health clinic setting. So, we've seen such a powerful impact of DoxyPEP on our STI incidence in our communities. And I think this is sobering to see the low proportion of high adherence, but also reassuring to see that we can see a high impact with quite low adherence across our systems. So I presented an update on our data from also from the clinic, and this is in collaboration with Matt Spinelli and the team here. What we looked at were all the individuals within the clinic who started DoxyPEP in a pre and post analysis, and we compared it to a number of individuals who had never started PrEP, even DoxyPEP, even though it was offered pretty routinely across all of our PrEP clinic clients. And we looked at this 5 quarters before and after. And what we saw was this. We saw that in the pre-period, among those who were initially started DPEP, we saw actually quite a steep rise in STIs overall, and a subsequent similar decline among the non-PEP users, DPEP users. And then after individuals started DoxyPEP, we saw this dramatic decline in STIs among the users and a relatively stable level among the non-users. So when we looked in the pre-period, that the DoxyPEP users had almost a 4-fold higher odds of being diagnosed with an STI. But in the post-period, there was really no difference, and that the rate was brought down to what we were seeing among individuals who didn't use DoxyPEP. And then when we looked among DPEP users by STI, you can see a similar pattern of a drop between from the pre to post period. And we saw significant declines in all STIs, including gonorrhea, which actually in many of the studies we had not seen a decline in gonorrhea incidence among DPEP users. And these numbers really sort of mirror what we've seen in the 4 clinical trials that have looked at the impact of DoxyPEP on STI incidence. And so it was really interesting that we're seeing this continued impact across our clinics. And we didn't see a similar incidence among the non-PEP DoxyPEP users in the clinic. So they pretty much had a similar decline in STIs that was pretty stable, as you can see here. Interestingly, one of the things that we were looking at is why we had such a high rate among the DPEP users. And one of the things that our clinicians have pointed out is that once somebody has an STI diagnosis, that becomes the impetus for them to start DoxyPEP if they've been considering it. So we were moving people into DoxyPEP after their STI diagnoses across the clinic. And one of the big things that comes up is around tetracycline resistance in gonorrhea. So this is a study out of Vancouver that looked at about 2,700 people who are receiving HIV treatment or PrEP in their clinic. And what they looked at was those who were enrolled in a DoxyPEP program. And they looked at in sort of during the time period from 2017 to 2020 during the HIV PrEP scale up. And then what happened during COVID-19 lockdown. And then as we came out of lockdown, what happened in the early DoxyPEP era and then the DoxyPEP scale up. And so what they saw was that during the PrEP scale up time period that tetracycline MICs were high at about 4, and then they dropped during COVID-19 actually down to 1. And then in the early DoxyPEP time period, they sort of started to rise, and then during DoxyPEP scale up, they continued to rise and essentially returned back to what they were during the PrEP scale up period. And so what the authors really concluded was that there was a variety of factors that were driving this increase in tetracycline MICs. It was essentially returning to the time period before during PrEP scale up, and that there may be changes in sexual activities among the folks who were in this clinic and in our communities during the COVID-19 that drove it down. So what we're seeing is a rise, is actually a return to what it was before some of the COVID-19 lockdowns, and giving us some insights into what might be driving some of this tetracycline resistance. There's also an interesting study out of Italy that looked at antimicrobial consumption among DoxyPEP users. And what they evaluated was what was the result of prescribing DoxyPEP to the folks in MSM in their clinic. And they had about DoxyPEP use around about 30% of the MSM, and they had follow-up about 15 months before DoxyPEP and 10 months after. And they did see a decline in STIs, as you can see here, before DoxyPEP and then after DoxyPEP. And what they looked at was what did they see, what did they observe in terms of antibiotic use for doxy, penicillin, and ceftriaxone, and what was expected based on the number of STIs that if they had continued in the after DoxyPEP period. So when you look at doxycycline, the days of therapy per 100,000 people was observed to be much lower, even for DoxyPEP among those, than it would have been expected. And it was also lower for penicillin and for ceftriaxone compared to what would have been expected. So even among doxycycline use overall in the clinics, that with DoxyPEP, we're actually using less antibiotics, including less doxy in individuals when we're rolling out DoxyPEP than we would have otherwise. So really, I think some of the impact of DoxyPEP, we actually might be using overall less antibiotics, including doxycycline, which I think was a little bit surprising for some of us. And there's also this really interesting modeling. So I wanted to touch on HPV vaccine study that was shown that really sort of reflected that we have these massive global disparities in HPV vaccine coverage. This is for girls who are less than 15 and receive their first dose of the HPV vaccine, and similar results for boys. And what the author really pointed out was that we have these large gaps in vaccine coverage, and some of this is driven by cost. So in the US, where we use HPV-9, it's about $240 per vaccine. And then there's now a new generic, which is HPV-4, that's actually $2.5. It's made by, I believe, by the Serum Institute. And what they suggested was that we could get to a 90% coverage of HPV vaccination if we move to this cheaper vaccine option, which would essentially account for 12 days of sales of our current HPV vaccines. And so really the financial ability of us to do this is actually quite feasible and within reach to sort of expand massively to cover 90% of all children with the reduction in cost. So this is a brief STI prevention update. So what I think was really interesting was that, DoxyPEP, we're seeing high uptake and sustained reductions across clinical settings, that we actually think that there's data that doxypep might actually reduce overall antibiotic use, including doxycycline, and that we're seeing this resistance in tetracycline-resistant gonorrhea increasing and returning to pre-COVID pandemic levels. I think some of the resistance to using doxypep for prevention might be, we might be able to use some of this data to support pushing this forward, that we have this continuum of doxypep that mirrors the PrEP continuum, and that moving to these generic HPV vaccines might provide us with an opportunity to really expand globally HPV coverage so that we can prevent HPV-related cancers. So we're have some time for questions, and thank you for attention.
Perfect. Thank you so much, both of you. Two fantastic talks. Let me walk around with this tiny microphone and take questions from the audience first for either Dr. Buchbinder or Dr. Scott.
What are the plans to further any of the research that's being done for women for less frequent dosing? I mean, we have these intriguing data. What's next?
There is a plan within the HPTN, depending on how things go with funding, to actually try to study different regimens in women to see, it won't be an efficacy trial, but it would at least give some initial, they'd at least do PK data and then try to look for breakthrough infections in high-risk women with alternate dosing.
Along that, excuse me, along that same line, I know that we see quicker loss of the drugs in the female genital tract. Do we see similar loss in like rectal tissue in women as well?
No, the rectal tissue is the same as in men.
Just check online. We hadn't had questions yet.
And I will say there's also a study that is taking place in men who have sex with men and transgender women, looking at TAF-FTC as a one pill before, one pill after, because it's got a more rapid onset of activity. So that will be exciting when we see those results.
That's great. One question from online is, could you share a little bit more about how easy it is to remove the in situ implants in humans?
That I don't know. It sounded like it was not a huge like surgical procedure, but I don't really know. I don't think it's been that these had not yet been tested in people, but it was good that they weren't migrating, and it was good that when they took them out, they took the whole thing out.
But it's not self-contained.
I was
It is.
I was so curious. I was like trying to look up a picture online because I'm imagining this as being like a blob in there.
Yeah.
And then how do you scoop
How do you get it out?
as
I know.
opposed to like a silastic implant, which
Yeah.
we have more experience with. So
Yeah.
yeah.
Yeah. I don't know how they scooped it out, actually.
Any last questions? Great.
I was interested in the last HPV coverage question, the last section, and it certainly seems reasonable that switching to generics would improve coverage, but it seemed like Gavi's vaccine price was already really low in a lot of areas of the world where you'd expect there to be low vaccination coverage because of cost, probably are getting the bulk of their vaccines from Gavi. So I was wondering if that was addressed, or I mean, is the gap is between sort of the formulation that we have in the United States, where maybe there are other barriers to HPV vaccination other than purely price, but maybe I'm misunderstanding.
Yeah, I don't think the authors were suggesting that price was the only driver for the low vaccine coverage, and absolutely that was the biggest differential. So that would have been the largest reduction in overall cost. But there were strategies to expand access with lower cost vaccinations is going to have to come along with a lot of other support for sort of education, outreach, and those kinds of things.
I can't even.
Hyman, I was just curious in your data from Magnet Stret with gonorrhea, I think we've all been puzzled by when and how doxy works for gonorrhea. And that one hypothesis is that the soonest you can take it after sex, the better it will work based on the PK data for genital tissues. And I know you guys have a really great data capture system. And I know maybe Susan, you are, I don't know if Stephanie's here too, but do you try to get any data on when people are taking in relationship to sex? Because we know it's a 72-hour window, but I think 72 hours is probably too wide for gonorrhea. And I'm very intrigued when I do see it working well in some studies, but not others, if that gap is one of the issues.
So it's, as you know, it's really hard to collect these event level data, even with apps that we have created, because people don't always fill them out. So, we don't collect that data. We sort of asked them, in the last, I think since their last visit, like how often did they take it within 72 hours? I think what we've geared towards, because I don't think we're really going to get those data. What we've changed our approach towards is actually sort of messaging around when they should take it. So we really start with 24 hours is where we tell people like that's where you should be taking it, like on your way home. And then, but you have until 72 hours. So that's the messaging. And I think that messaging hasn't been universal. And so I think that might be one of the reasons why we're seeing it, because we're really trying to message that in all of our counseling with our clients.
Fantastic. We have a couple more questions from online, and then we'll switch to the second part of our program. One question for Dr. Buchbinder. Can you talk about the role of HIV RNA viral load monitoring in the context of IM CAB for PrEP, even if patients have delayed or late injections? Do you have thoughts about its use there?
Yeah, so I mean, I think that the challenge with using RNA testing is just that if they have a really delayed or late test, then some people would probably use an RNA to screen to be sure that they're not truly infected. But if they're a little bit late or they're actively on CAB-LA injections, the risk of breakthrough is so low that your false positive rate is just going to be very high. And so you're going to end up chasing just a ton of false positives.
Fantastic. And one related follow-up question was about HPTN 083 and 084. Were there particular methods, and could you share a bit more about how it was determined that there were false positives?
Yeah, so they followed people with, so first of all, what Rafi presented last year is that if you did another RNA test, a second RNA test, that almost always ruled out a false positive, or it determined that it was a false positive, that a second RNA test is probably what's required to rule it out, and that worked really well. So they did a lot of subsequent testing, and then they had an adjudication committee to try to figure out what was true infection from what was a false positive.
Thank you so much. And then last question for Dr. Scott. There's a question about the DoxyPEP continuum study from Embury, and whether, and a bit sharing more about the guidelines they were using as to who was eligible for DoxyPEP, in that many guidelines are tiered by recommend, offer, et cetera.
Yeah, so we know that there's a very wide spectrum. I think California state guidelines are probably the most inclusive and liberal. So within our clinic, what our guidelines for DoxyPEP indication is, among our PrEP users, for example, for most of them, HIV is an STI. So we offer DoxyPEP to all those individuals. And then we use a shared decision making. So we offer it, it's available in the clinic. We educate our clients about it, and then they can just choose. So we use the guidelines from the health department for this analysis, where it was a tiered approach. So it was for recommended or offered. Those are the criteria that we used for DoxyPEP indicated.
Fantastic. Thank you so much. Let's give them both a round of applause. Okay, and before anybody goes anywhere, we are going to transition to the second part of our program to end the morning. We are really lucky to have a special guest here, Dr. Meg Newman, to speak a little bit about her eponymous teaching award, and I'll turn it over to her. Thank you so much, Dr. Newman, for being here.
Well, I will just say it's an honor to be here for sure. And, you know, I'm slightly outside of the division, and you should know you're all doing awesome work, being led really well and doing awesome work. So it's an absolute honor to be here. So some of you, all of you know what a beloved member Liz Embert is of our faculty. She is the heart and soul of many things, but particularly the Ward 86 pop-up clinic, which serves people with HIV experiencing homelessness. And she has led and moved through that with a lot of grace and beauty, with opportunity to lead with moral clarity, love, and opportunities to teach students, residents, and fellows. You all know she's a consummate clinician, and it's a complete honor to be able to share this award with her and to be actually physically here today. So without further ado, I think there's some people in the audience that you might be surprised to see. Yes, in fact, yes, lots of people. And yes. Oh, yes. Whoop. Okay. So I'm going to turn this over to Monica. And again, congratulations, Liz.
So congratulations, Liz. We wanted to just tell you about the Meg Newman Teaching Award. It was established in 2006 and really honored the exceptional teaching and clinical care that Meg Newman really exemplified at Ward 86 and in the inpatient HIV wards for so long. 1995, I came from Harvard as my last year to do, because I really wanted to be at UCSF. And I was on the HIV consult service for a whole month with Dr. Newman, and it completely set the course of my career. Each year we honor a member of the faculty with the Meg Newman Award, and just for Liz is to say that you're so well deserving. I had a conversation with you to lead pop-up, and you were really thoughtful, and you didn't tell me right away. And it took you a week, and you may have even talked to your husband about it. And then you came back and said, I'll do it. Meaning when you decide to do something, you're all in, and you were all in, and you formulated it. You're the heart and soul of it, like Meg said, and you have really taken it to incredible successes. So thank you so much for your work in pop-up, and you're so well deserving of this award. Congratulations, Liz. So we'll just have you photograph it. And I think any other former winner, please, right? Like we did last year. So Annie here. Annie right now. This is for you. Where's the clock though? I think it has. Oh, thanks.